I guess we're ready to move on. The other part of our day today is so this is the next set of talks. There's 3 presentations together, and we're going to run all 3 in a row. They're not lightning talks; they're actually full presentations, but there are 3 parts of a program. So RCAP Solutions in Massachusetts has been working with the Health Foundation of Central Massachusetts and the Education Development Center. And Jim Starbard is one of the speakers here, and he and I have known each other quite a long time. Jim's been working on the private well program there. And so they've got this funding to do this project from start to finish. I believe it's 5 years long, and I'm not going to spoil it all. I'm involved a little bit as just to help out in some of the committee meetings, but it's really interesting because it takes things from start to finish, collecting real data to show there's a problem, to looking at how we might affect real change in central Massachusetts to help the well owners that have those issues. And so today there's 3 presentations. The first is by Amie Shei from the Health Foundation of Central Massachusetts. The second is Jim Starbard from RCAP Solutions. And the third is from Kim Dash, who's with the Education Development Center. And the title of these presentations together is An Innovative Partnership to Address Private Well Issues in Massachusetts, 3 Perspectives: Funder, Field Sanitarian, and Evaluator. All right.
Hello. Thank you for joining us for this presentation. My name is Amie Shei, and I would like to share with you the Health Foundation's perspective. I am the Vice President for Programs at the Health Foundation of Central Massachusetts. I've been in this role since 2016. In terms of my background, I have a PhD in health policy with a concentration in evaluative sciences and statistics. I've had a long-standing interest in looking at the health impact of programs and policies, especially among vulnerable populations. And prior to joining the Health Foundation, I worked in healthcare consulting and also taught community health. This is just a brief roadmap of my presentation today. I'll first provide an introduction to the Health Foundation and then tell you a little bit about our unique synergy initiative approach to addressing complex health issues. I'll say a little bit about the role of evaluation in our synergy initiative projects, and then I will introduce the North Central Massachusetts Private Well Program. The Health Foundation is what is known as a health conversion foundation. We were formally established in January of 1999 from the sale of the Central Massachusetts Healthcare Incorporated, which was a physician-owned non-for-profit HMO in Central Massachusetts. Our mission is to use the resources from that conversion to improve the health of those who live or work in the Central Massachusetts region, with a particular emphasis on vulnerable populations and unmet needs. In this map here, you will see our service area, which is shown in the blue shading. The red line represents the county borders. So our service area covers all of Worcester County in central Massachusetts and also some of the surrounding towns. This service area was set because it was the service area of the original HMO that was sold, which is why we have maintained this particular service area. We look to the CDC Health Impact Pyramid to guide our work in terms of addressing health and trying to maximize the impact that we can have on health. Many of our projects, especially the Synergy Initiative projects, tend to focus at the base of the pyramid, so on socioeconomic factors and changing the context. So these include projects related to poverty and education, housing. Sometimes our work relates to changing the context, very much like this particular project is trying to address private well water. Next, I'll provide a brief overview of the Synergy Initiative. This is one of our grant-making avenues here at the Health Foundation. It's known as the Healthcare and Health Promotion Synergy Initiative. We typically just refer to it as the Synergy Initiative. This makes up approximately 75% of our annual grant-making budget. And the grants typically total about $2 million each over an approximately 5-year grant period. These are collaborative projects that target health issues in central Massachusetts with comprehensive strategies aimed at systems or policy change. The projects typically begin with funding for a planning grant, followed by a pilot grant, and then 1 to 3 years of implementation grants. Evaluation and continuous quality improvement are expected throughout all phases of the grant period. So this here is an infographic just showing graphically what I just explained. So as I mentioned, we start first with a 1-year planning grant, which is pretty unique. A lot of other grant funding out there jumps right into the implementation phase, but we really see the value in having a dedicated year for planning when the lead organization can work closely with community partners to plan out what will then be a 1-year pilot, which is typically the 2nd year of the grant period, when strategies are tested out, evaluated, and refined before broader implementation in the final 1 to 3 years, with the end goal of achieving systems change that can sustain the intervention and potentially expand the intervention to other areas within the state and sometimes even beyond the state line. And as you can see at the bottom, evaluation occurs throughout the entire grant period. There are a couple key characteristics of Synergy Initiative projects, and they are summarized here. Significance of the program, level of integration, soundness of the application, capacity for enduring change, potential for impact, potential for replication, quality of the evaluation, and the exit strategy. These are characteristics that we look for when potential grantees come to us and apply for a Synergy Initiative grant. And these are also characteristics that we look for throughout all phases of the grant period. In this pie chart, you will see a snapshot of the Foundation's investments over the last 20 years of the Foundation's history. What you see here is both the Activation Fund and the Synergy Initiative. The Activation Fund is a separate grant-making avenue, which makes up about 25%. Those are very different types of grants from the Synergy Initiative. Those are typically annual grants. But as I mentioned, Synergy Initiative grants make up the bulk of our grant making. And you'll see that we have funded in many different areas, represented by all the different colors in the pie chart, ranging from oral health to healthy eating, youth development, economic self-sufficiency, children's mental health, homelessness, prisoner reentry. And a big reason why we have been able to fund in such diverse areas over the years is that we do not name issues. This is one way in which we're different from a lot of other funders out there. Rather than naming a particular focus area, we look to the community to identify the issues that are most pressing in the community and then to propose solutions to address those issues. We have been recognized for this Synergy Initiative approach. We recently concluded an external evaluation led by Dr. Doug Easterling at Wake Forest School of Medicine. And here I just pulled out a quote from a recent paper that was published in 2019 about how foundations can promote impactful collaboration. And he said, "Foundations have been attracted to models like collective impact because of the potential for synergistic strategies and large-scale impact. The Health Foundation of Central Massachusetts' experience with the Synergy Initiative demonstrates that it is possible for groups to generate impactful strategies beyond what they would have done on their own, and that funders can add considerable value to the collaborative process. But it also shows that this is an intensive process that requires commitment, action, deep thinking, and stretching of boundaries on everyone's part. So some of you may be familiar with collective impact and that approach to grant making. That approach has actually been informed by the Synergy Initiative, which was created prior to collective impact. And it really is a way to approach complex problems in a way that engages many different community partners in this collaborative work and helps to achieve the most impact possible. An important piece of our Synergy Initiative approach is that empowerment evaluation is a key component of our approach. It's an approach that aims to increase the probability of program success by providing program stakeholders with tools to assess planning, implementation, and self-evaluation of their program. And it also mainstreams evaluation as part of the planning and management of a program. So some grant-funded projects engage in evaluation at the conclusion of that grant-funded project. We actually involve evaluators from the very beginning, even before an application is officially submitted to the Health Foundation, because we recognize the importance of engaging evaluators in this work in order to maximize our impact. So you'll see here in this infographic what a traditional grant evaluation model looks like, where in the first stage, which is really the grant period, you have the grantee carrying out the grant-related activities and the funder kind of observing what is happening. And then in the second stage, typically after the grant concludes, the funder then works with an evaluator to examine the impact of that grant. So it is really a separate two-stage model. This is what is typically used in many grant-funded projects. Our evaluation model is a little bit different. You'll see in this Venn diagram that we really recognize the importance of all three parties working very closely together through all phases of the grant period. So the applicant, even before an official application is submitted, and then once the grant is funded, that organization becomes the grantee, works very closely with the funder and evaluator to achieve the best results possible. Here, I just wanted to highlight a couple examples of systems change that the Health Foundation has been able to achieve through these grants over the years. We have many more examples on our website. This also just highlights the diversity of topics that we have funded over the years. I know these are probably less relevant for those of you participating in this conference, but just wanted to highlight a couple examples of systems change and what we mean by systems change. The first project on here is Together for Kids, led by an organization known as Community Health Link. This was one of our first round Synergy Initiative projects starting in 2001, and it developed a new system of mental health consultations for preschoolers. So at the time, there was a very high rate of preschool expulsions in Worcester, and the project was successful at reducing that rate to nearly zero. As a result of that successful model, the state has since funded mental health consultations in the preschool settings for over $13 million since 2008. So this is an example of achieving systems change that is sustained. The state has picked up funding for this initiative since this project ended, and the model has also been replicated outside of our central Massachusetts service area to cover the entire state. Another example is a little more recent, the Worcester Initiative for Supported Reentry, led by an organization known as Advocates Incorporated. This was a round 3 project, and it is a prisoner reentry program that provided access to healthcare services, housing, employment training, and placement for individuals returning to the community after after being imprisoned. The project found that the 3-year recidivism rate was reduced by 47%, which is a very significant decrease. And as a result, the State Office of Probation is replicating the model in select community correction centers across the state. So again, another example of the critical role of evaluation in demonstrating the impact, and then that impact being used to advocate for sustained change at the state level that can also be replicated beyond our Central Massachusetts service area. So next, I'll say a little bit more about this particular project and how it came to be. Jim will also tell you a little bit more about the project background in his presentation next. But RCAP initially applied to the Health Foundation for Activation Fund grants in 2017 and 2018. As I mentioned previously, this is a different type of grant. Activation Fund grants are typically annual grants. And they are aimed at helping an individual organization increase its capacity in a way that can be sustained over time. So typically they focus on one particular organization, and they're less about systems change and collaboration. In this case, RCAP was looking to expand its EPA program to provide more in-depth water quality testing and technical assistance to homeowners in Central Massachusetts. The end goal at the time was a successful regional pilot demonstration program for private well owners, a website of resources for homeowners, and also a quality map of the area. And the hope was that a coalition would come together with a plan to move forward to push for private well regulations. So from our perspective here at the Health Foundation, we felt that RCAP made a strong case for the need to address contaminants in private well water. Many people are unaware of the potential for contaminants in private well water and also the lack of regulations in this area. But at the same time, the Activation Fund did not seem to be the right avenue for this type of project. Few reasons why we felt that it wasn't the right fit was that the proposed project would require ongoing funding to continue following the grant period. And these tests, these water tests, can be quite expensive, as much as $1,200 for a PFAS test or around $150 for a standard test. And also, we felt that this grant would not help solve the underlying systemic issues contributing to potential contaminants in private well water, and also the lack of awareness and lack of regulation of private well water. So the foundation suggested to RCAP Solutions to explore the Synergy Initiative in order to seek systems change to address the lack of statewide private well regulations, and also to have a broader impact beyond the individual homeowners that may be affected by a given grant. So that began what was the evolution of this idea, which started as an Activation Fund idea, to what became a Synergy Initiative project. And the ways in which this happened was that the scope of the project was expanded from what was initially proposed for the Activation Fund. So RCAP Solutions proposed a greater number of homeowners and target communities to participate in the grant, and also the development of a revolving loan fund to assist low-income homeowners that may not be able to remediate wells with contamination issues. It also led to additional partnerships to address this complicated issue. So RCAP Solutions pulled together a leadership team to really guide the strategy of this project, and also an advisory group that the project team can turn to from time to time with advice about various things as the project moves forward. So Jim will say a little bit more about these partnerships in his presentation. Evaluation was also added to this project as it evolved into a Synergy Initiative project. Activation fund projects, because they're shorter in length and they are typically more discrete, do not typically involve evaluation. For synergy initiative projects, evaluation is a critical component. So RCAP Solutions was paired with an evaluator through what we call a speed dating process. Before synergy initiative applicants submit the final application, they are introduced to potential evaluators, and the evaluators also meet the potential projects in what we call a speed dating session, sort of a round robin where everyone meets in person. And this was pre-COVID, when people could still meet in person, and they essentially speed dated and learned about each other, and then provided their rankings to us here at the Health Foundation, and we matched up projects and evaluators, and the evaluators then helped the applicant prepare the final application and incorporate evaluation into that very first application for a planning grant. Another way in which this project evolved to become a synergy initiative project was by building in advocacy, which is necessary for achieving systems change. So this ties in closely with evaluation, because you do need rigorous data to take with you to advocate for systems change when you meet with legislators and other key stakeholders. But advocacy is an important component of these projects, especially in the latter stages of the project during broader implementation. So RCAP Solutions applied as what was round 5 of the Synergy Initiative for the Health Foundation. And this is just a quick overview of the timeline back then. So RCAP Solutions submitted one of 20 letters of intent that the Health Foundation received. Of those, 6 were invited to submit full applications. And as I mentioned previously, those applicants were invited to a speed dating session to meet with professional evaluators. They were then matched up to prepare the final applications. The final grants were awarded in December of 2019, and the 4 successful grants are listed here. As you can see, there's a wide range of topics because of the way we approach our grant making, as I mentioned previously. The first relates to developing a new system of foster parent support in the Worcester area. The second is this particular project here related to private wells. The third is the Quabog Connector, which aims to develop a new system of rural transportation that can be sustained. And finally, the Ready Go project is a workforce development program for early education and childcare providers. So this particular project began with a planning grant in 2020. It was a $2,000 grant, and as part of that planning year, RCAP Solutions and partners reviewed local regulations throughout the target area and looked at examples from other states that have adopted statewide regulations of private wells. The team also worked together to develop a plan for the pilot. During the planning year, it was decided to exclude PFAS from testing because of ongoing MassDEP testing for private wells and also public water systems, which is currently going on right now. RCAP Solutions also conducted some complementary water quality tests and well assessments to really understand the process and to inform the development of the pilot for this year. And it was decided to postpone the work on the revolving loan fund until the project is farther along and we have a better sense of just how much remediation might be necessary and what those costs might entail. We're currently in the pilot year in 2021, what we call a pilot grant. RCAP Solutions was awarded $425,000 for this year. And the aim of this year is really to pilot the water quality tests and well assessments and education in 6 pilot communities in North Central Massachusetts. The plan is to test 40 households in each pilot town for a total of 240 households to be tested in this pilot year. There's a phased approach that was designed in consultation with our evaluator, Kim Dash, whom you'll hear from later on today, to ensure a rigorous study design. And we've also begun working on the advocacy plan to engage key legislators and stakeholders about the problem of potential contamination of private well water and potential solutions. These strategies will be evaluated throughout this pilot year and revised as needed before broader implementation in the years to come. So that concludes my presentation, and I will turn it over to Jim to provide his perspective, and I look forward to your questions later this day. Thank you very much.
Hi, good afternoon, everyone. My name is Jim Starbard. I'm the Massachusetts State Lead, and I'm here to talk to you about the environmental health perspective of our Central Mass Private Well grant. Just before I start, a little bit about myself. I've been employed at RCAP Solutions since 2009. Previous to that, I was a local Board of Health agent, sanitarian, for 7 years. I hold a Master's of Science in Occupational and Environmental Health and Safety. I have a Bachelor's of Science in Health Science. I'm a registered sanitarian through NEHIRE as well as the state of Massachusetts, and also a Massachusetts Certified Health Officer and Drinking Water Operator. I'm also a health and home specialist. So just a little bit of background about why the program was needed. Local boards of health in Massachusetts enforce many statewide public health codes. Examples would be Title V, which is our septic code, the housing code, the food code, swimming pools, summer camps, you name it. They all come out with minimum standards from the state and the local boards of health to enforce. And local boards of health can make regulations more stringent than those state minimum guidelines, but not any less stringent. And Massachusetts has no statewide private well regulation, so the state does not put out a minimum standard like all these other regulations. MassDEP puts out a model regulation, which is basically a regulation with minimum standards that MassDEP feels that each of the boards of health should adopt, and makes it in a way that they can easily adopt it. However, in order for it to actually be law in each of these municipalities, each of those 351 boards of health has to adopt that private well regulation, which they can be either more or less stringent because it is not a minimum standard from the state. So why did we get background for the program? Is we were looking ways to add sampling to our US EPA private well program, which we've been doing for a number of years now. Under that program, we're allowed to do well assessments, which is like a sanitary survey for a private well, and give a lot of information to the homeowner. However, we felt that having an actual sample of the well during that assessment would give us a lot more information for the homeowner. We have had previous grants from the Health Foundation of Central Massachusetts, one dealing with community septic plans, one dealing with asset management planning. So we felt that going back to that funder for an application under a private well initiative would be a good place to start. So we did apply 2 different times under what's called the Activation Fund, which is a 1-year smaller amount of money, which was the original grants we had from the Health Foundation for the other programs. We were advised on this after the second application that it would be more fitting for an application for the what they call the Synergy Initiative. So we did apply for that the following year, and it was a long process, but we were at the end of it, we were funded under the Synergy Initiative for the private well program for up to 5 years to work on this program. So that would spawn the North Central Massachusetts private well program. Like I mentioned, it's 5 years and has different goals. One is to educate private well owners on the importance of well maintenance and testing, help local boards of health either update or implement local regulations, give technical assistance and sampling for the homeowners. And really the ultimate goal was to get a statewide minimum private well standards adopted in the Commonwealth, just like we have in other private well codes, public health codes. So that, make it so that each and every Board of Health would be regulating a private well in a uniform fashion. Again, they can be more stringent, but at least have a minimum standard throughout the state. So this is the target region. For reference, for those not familiar with Massachusetts, the straight line at the top of that map would be New Hampshire. So it's the middle of the state and the northern part of the middle of the state. Our two regions that we targeted and were our initial partners when we applied were the Massachusetts Public Health Network, which is a network of a bunch of boards of health on the left side of your screen here. And then the Shei Associated Boards of Health, which is basically the represents the right side of your screen here. Little difference between the networks and the boards of health. The Massachusetts Public Health Network is really a network of each town has their own health agents, and they share services and work together as much as they can. On the right side is the Shei Associated Boards of Health. They actually act as the health agent for each of these towns and have the environmental health and public health nursing staff for these towns. So that all that requirements are taken care of that. Each of these towns still has their own Board of Health and still has autonomy, but just different ways of doing the work. So why did we pick this target region? Well, it was already known from USGS the high in arsenic, uranium, and radon. It's also an area where PFAS chemicals, PFAS-like chemicals in the groundwater are becoming a big problem. And just a little additional information, in Massachusetts, as of this year, we now have a maximum contaminant level of 20 parts per trillion of 6 of the PFAS chemicals. So as it became a regulation, more testing's been done, and it's become more of a known issue in the target area. So our initial partners when we first applied were the Massachusetts Public Health Network, and the Shei Associated Boards of Health, as well as MassDEP and the Massachusetts Environmental Health Association. Massachusetts Environmental Health Association is the Massachusetts branch of the National Environmental Health Association. And the funder was the Health Foundation Central Massachusetts, and that's their logo there in the bottom left. So like I mentioned, it's a 5-year grant. We are currently in the 2nd year, but for the first year in 2020 was the planning year. So of course we did some planning. And as pretty much everyone else had to deal with, we did have a pandemic delay. We did have a grant announcement in the summer of 2020 that was finally done later in the summer than we expected due to the pandemic. We formed leadership advisory teams and we did some field work. So next slide, they'll be talking each parts of that. So planning, one of the questions was, and initially when we put this program together, we were going to test for PFAS, the 6 PFAS chemicals that Massachusetts is now regulating. There's been a lot of back and forth about that. There was a lot of challenges being a new regulation. There's also a waste site cleanup regulation, so it's another layer of concern. And also MassDEP was doing their own PFAS sampling as part of a program that rolled out when they put the PFAS regulation in effect. So at the end of the discussions, we decided that we were going to stay away from PFAS sampling. I'm going to leave that up to MassDEP. And we decided to test for all the contaminants and Mass Associated Health Boards, and MassDEP recommends mostly naturally occurring contaminants. And so we focused on those and left the PFAS sampling to the MassDEP program. We also came up with a logic model, which I'll let Kim speak about more when her presentation, but it's basically a reason for why this program would be successful and how to base that on outreach plan and how we get to the communities and the people. A needs assessment to really look at the needs of the communities as well in the private well realm, and base our program on that. And also collaborative survey when we made sure that our partners and our advisory teams were working together in a collaborative manner. Again, a lot of these will be discussed by Kim in the next presentation, so I won't go too far into them. Pandemic delay, we were hoping in the early spring to really launch the field work of the program and work with the board of health and outreach. But due to the pandemic, we decided to let that be in the back burner for a little while because the boards of health were really inundated with the pandemic, as we can imagine. So, but the Health Foundation, we did find a role that we could play, and the Health Foundation did approve supplemental funding to work with local medical reserve corps on COVID-19 pandemic outreach to in-need seniors. And this is working with the Massachusetts Medical Reserve Corps as well as the Worcester Medical Reserve Corps. So basically the whole Central Mass region. And throughout that initiative, we were able to distribute, and this was really in the beginning of the pandemic stages when, getting knowledge out to those in highest risk was at great need. So we ended up distributing up to 20,000 door hangers in Worcester County to seniors, really looking at the senior housing and other at-risk facilities. And the COVID-19 safety messaging was in English and Spanish. In the next slide, I'll show you what the actual door hanger was. It was a highly successful program. We were able to really get through to all seniors and really the at-risk populations. And we were very happy to be able to assist in the time of the pandemic starting, getting the word out and continuing the work with our local health people and in that time of need, just like they were working with us when the private well work started. So we had a grand announcement, home run recruitment. Again, it was a little later than we expected due to the pandemic, but basically did it all together. It was going to be two different events, but we were looking for homeowner recruitment for our assessment sampling program as well as announcing the program, so we kind of did it all at once. It included press releases, email blasts. We have a lot of lists that we've included over the years. Direct mailing to towns and elected officials and representatives, state reps, state senators, even the federal delegation. Really did a focus on local paper, especially the weeklies in these smaller towns. Really get the word out in the towns that we're really targeting. Local TV, we had the opportunity to go on a few local cable shows to discuss the program. Social media, we actually got a really great Twitter handle, or What's in Your Well Water. Our communications department was able to get that one. I thought it was a phenomenal hashtag, and I'm very happy to get it. And I think will be a hashtag we utilize long after this program is concluded, as well as updating our well webpage and making out a whole new webpage just for this private well program in Central Massachusetts. And again, I was very happy to hear about the Twitter handle, What's in Your Well Water, and so I just wanted to give it an extra slide to that. And this is just a posting of our latest posting on that. Recruiting homeowners for this year, so this is 2 of the towns that we're working in this year. There's 6 that we're working in this year. And recruiting homeowners for the well assessment and testing program, which it's been highly successful, especially in Boxborough. I think we're almost to the numbers we were looking for. And also I want to mention the website. We did a lot of additions, a lot of homeowner tips, but happily I wanted to just show you this one part is What's in Your Well Water, 3 easy steps to drill down some answers. Basically what to test your water for. We're bringing a link to what MassDEP and the Mass Associated Health Boards recommend you test your water for and how often to test that water. Number 2, where to get your well tested, will bring you to a link right to the MassDEP certified water laboratories in the state. And what does your well water test mean? That'll bring you a link right to the Be Well Informed tool, which New Hampshire initially developed, but Massachusetts has adopted and brought to our drinking water standards down here. So using those 3, we thought it would be a really good 1, 2, 3 step for homeowners to get some better knowledge of their drinking water in their well. So this is the leadership team as construed today. You might have remembered from the other slide that we had the initial partners. As we develop the leadership teams, the advisory teams, we're looking to grow the ranks, if you will. And so again, we had the Neshoba Associated Boards of Health and Massachusetts Public Health Network and the Massachusetts Environmental Health Association, MassDEP, which were there before, but also we brought on a Safe Well, which is a private well, private company. It's based in Bolton, Massachusetts, which is a town in one of our target areas, and they bring great, great public sector, private sector knowledge, and also some great water, private well water results to the program. They've been a great addition to helping us out. The private well class, Steve Wilson, is on our leadership team too. He was on our advisory team last year, but brought too much to the table to keep him as an advisor, so we're bringing him up to the leadership team. And we also state senators and state reps that within the target region are joining the team and hope to bring on more. Again, like I said, the statewide minimum standards for private wells really is our goal for this program. So having a legislator is in the program is highly advantageous to that goal. And also we have some advisory team members. Like I mentioned, a few of the advisory team members have gone up to the leadership team. So we are looking to recruit more in the advisory team, but we have some great members currently. Dr. Pipe from Northeastern University gives a great, knowledge too of the studies and drinking water knowledge as a whole. The Community Health Network Area 9, which is Area 9 is North Central Massachusetts, which is our target area for this grant. And also we have the former president of the Massachusetts Realtors Association, which owns Patriot Real Estate. So he advised us on the real estate angle of the private well program. And also, you know, with statewide regulations, I'm sure the realtor community will want to have a seat at the table. So we're very happy to bring him on board to get that seat at the table in the early stages, if you will. So field work, this was done in the first year. We did 21 well assessments just to kind of test out the program with sampling for the mass recommended contaminants. Full reports are sent to participants with completed well assessment form, the testing results. We do record checks for well and septic records for any home we go to. So we get forward those records to them as well. If any problems are found or any, you know, if sample comes back bad, we'll send them remediation info, things to treat, how to treat, you know, what kind of companies to go for, how to find you know, what to look for when hiring a contractor, other kinds of helpful information like that. When everyone, regardless of what we find, gets testing information moving forward in their well assessment package, so basically tell them what to test for and how often to test for it moving forward. You know, small sample size last year. It was only 21 samples taken. And this year we're doing 240. But just the, you know, percentage-wise, it showed that you know, 57% of those had some sort of water quality issue that was flagged by the lab, whether it be a maximum contaminant level, like the, you know, the big ones that I'm below, like E. coli, chlorofluorocarbon, arsenic, lead. Some of them could be, you know, sodium chloride, you know, magnesium. So we had manganese, I'm sorry. But so, you know, we had a lot of different results, but it showed that, you know, over 50% had some sort of water quality issue that we're at least able to advise on and hopefully give recommendations to help the homeowner correct. We were kind of interested to see how much interest we get for the pre-sampling and sampling and well assessments, and we're happy to see that we had over 100 requests that we couldn't even accommodate, which was you know, it was great to get that kind of numbers. So the top of those requests, they were emailed last year saying, sorry, we can, you know, accommodate you this year, but we will keep you for next year. And of the 6 communities, any of those that were working this year, any of those that signed up last year will be top of the list to get this sample and well assessment this year. And also we'll try to, you know, fill in the rest, if you will. And as the program moves out, those ones that signed up the first year still will be in the loop to get their testing done as things move forward. So pilot year 2021, out of the 25 communities, we are working on 6 target communities this time, doing it 2 at a time, 1 from each of the health network, health associated boards. It was really based on the interest we got from 2020, from homeowners as well as from the boards of health that we interacted with. The community primarily uses private wells, of course, because it's a private well program. We don't want to get in a community that has a public water system serving most of the community. And again, you know, two towns at a time, 3 from each health district at a time. So each of the health district network partners will be served. And I'm looking to do 40 well census and sampling from homeowners in each of those the 6 communities, education outreach materials in that community, and really engage the boards of health and help promote an adoption of the model regulations. You know, some communities we're working in, some have you know, good private well local regulations, some haven't looked at them in years. So there'll be a mixed bag there, but we'll be there to assist each of them if they choose to update them. So the outreach that we've already done this year, official letters went out to town managers and the Board of Health. We plan on meetings. The towns we're working in currently, we've already met with the Board of Health and Select Board, or we're going to set up meetings with them as the program rolls out. We're this year is May through October, so 2 months, you know, 1 month per town, 2 months in 2 town segments, if you will. You know, announcement in local media. We've done another website update for this year's program. So again, really getting the outreach back out to towns and powers that be. And in conclusion, I did mention that PFAS sampling was done by MassDEP, so I figured I would just put a slide into this. MassDEP program, all public water systems in select towns, private wells are eligible. So of the 6 towns we're working in 2021, 5 of them will be sampled under the private well PFAS sampling program MassDEP is running. And programs are almost running simultaneously, and we're both doing 40 samples per town. So we did have to definitely make sure our materials showed that we are a distinct program from MassDEP's, and actually supply MassDEP's link for the PFAS sampling program as part of our materials. So you know, having 2 private well sampling programs in the same town at the same time is a little not common, but you know, we were able to hopefully distinguish ourselves from that. And again, we're doing 40 private well samples per community. And that's going to be all for my part, and I'll turn it over to Kim for her section now.
Hi, everyone. My name is Kim Dash. I'm a principal research scientist with Education Development Center in Waltham, Massachusetts. I am working with the Health Foundation of Central Massachusetts and RCAP Solutions to evaluate the North Central Massachusetts Private Well Program. And I'm going to be talking with you today about the evaluator's perspective with regard to the pilot study that we are conducting with RCAP Solutions. So this is me up on the slide. I bring quite a bit of experience working with community-based organizations to evaluate programs that are really locally responsive. And on this project, I serve mostly as an evaluation guide or coach and critical friend who helps RCAP Solutions design and implement evaluation activities that will help them answer questions they have about their program's effectiveness. And this is the program that Jim just described. And my approach emphasizes collaboration with RCAP and the Health Foundation. We all work really closely together to determine evaluation questions and methods. So the evaluation of the North Central Massachusetts Private Well Program is guided primarily by this evaluation framework, which you see here on the slide. This is the Centers for Disease Control and Prevention's framework, and it outlines 5 critical steps in the evaluation process. The first step is involving key stakeholders, including those involved in program operations, those served or affected by the program, and primary users of the evaluation data or results. And then the second step is about describing the program, including the need for the program, expected effects, activities, resources, the context, and including a kind of logic model, which I'll say a little bit more about in a second. And then the third step is focusing the evaluation design to assess the issues of greatest concern to all the stakeholders involved. And then 4, we gather credible evidence of effectiveness to strengthen our judgments or confidence in the recommendations or results of the evaluation. And then the 5th step is justifying conclusions by linking them to the evidence gathered and judging them against agreed upon standards that are set by our group of stakeholders. And then finally, we want to make sure that the evaluation results and the lessons we learn are shared and used. And so, we want to make sure that those results are widely disseminated using the most appropriate kinds of approaches in reaching the audiences we want to reach. And you'll also notice in the middle of the diagram on the slide that this approach applies a set of standards for judging the quality of program evaluation efforts. So when we talk about utility standards, these are standards that ensure evaluation will serve the information needs of RCAP Solutions, the Health Foundation, and all those stakeholders that Jim talked about when he was presenting. And the utility standards will help advance the legislation that Jim was talking about to promote regular well assessments and data collection on assessment activities in the state of Massachusetts. We also want to consider feasibility standards, which ensure that the evaluation activities are realistic and doable and cost efficient. We consider proprietary standards, which ensure that the evaluation will be conducted ethically and keep in mind the welfare of all of those who are participating in the evaluation. And so to this end, we developed a human protections protocol, which was approved by EDC's Institutional Review Board. And then finally, we consider accuracy to ensure that the evaluation will reveal accurate information about the components that determine the merit of the Central Massachusetts Private Well Program. So again, this is the framework we used, and the rest of my presentation is essentially organized according to these steps. So to ensure that the program and evaluation is responsive to local needs and is likely to be implemented with greater success, we are engaging many stakeholders who have different roles and interests in program implementation and evaluation. Jim has already reviewed these stakeholders, but I'd like to highlight a few who have been instrumental in helping with evaluation activities. So first, all stakeholders provided feedback on the evaluation plan and on data collection instruments. The Neshoba Associated Boards of Health, Community Health Network of Central Massachusetts, and the Montechusett Public Health Network are assisting with recruiting homeowners to participate in the pilot test. Steve Wilson at the University of Illinois provided guidance on well assessment protocols that are used with homeowners. Local water testing labs are responsible for testing water samples submitted and providing prospective data on homeowners or residents participating in the program. And another lab is providing normalized data or standardized data on retrospective well water testing for comparison purposes. And I'm going to say a little bit more about that a few slides later. And then finally, and most important, private well owners are providing feedback on well assessment services delivered through the program. So the North Central Massachusetts Private Well Program and pilot study are guided by a program logic model, which is predicted here. And this is what I was referring to when I was reviewing the CDC evaluation framework. This is our logic model. And a logic model, for those of you who are not really familiar with this, type of thing is a graphic depiction, or it's a kind of roadmap that presents the linkages or relationships among resources, activities, outputs, and outcomes or impacts for a given program. So here, as you can see, the program itself is designed to address high rates of well water contaminants in central Massachusetts, where rates of testing and remediation have been traditionally low. And these low rates of testing are attributable to multiple factors. So first of all, homeowners may not be aware of potential contaminants in their private wells. They may not see themselves as likely to get sick if they drink the water, or they don't know how often they should test their well water or how they might go about doing that. And then second, while homeowners in the state of Massachusetts do have their well water tested, most of this testing is conducted by private companies at the homeowner's request, and information on such testing and results are not tracked in any systematic way. So we have no good data on the volume of testing that's happening in Massachusetts. And we don't have a complete picture of contaminants by town, nor any understanding of how such tests are completed in regions suspected to be at high risk for groundwater contamination. Furthermore, many homeowners are not able to afford remediation when their well tests indicate that contaminants are present. So it is possible that homeowners forego testing, knowing that they would not be able to afford to address any problems found. And then finally, in Massachusetts, private well testing regulations vary by town. Some towns have stricter regulations which require that well tests be conducted during real estate transactions, new rental agreements, and new constructions. However, most town regulations do not require such testing. So program activities are designed to address these kinds of contributing factors. Education that includes online curriculum and educational materials for homeowners, renters, buyers, and realtors on sound wellhead protection and well remediation, and Board of Health staff training on outreach and well water assessment are designed to address health beliefs that deter testing. Development of and advocacy for model well regulations and testing or reporting or data collection guidelines based on those implemented in other states, such as New Jersey and Connecticut, are meant to address issues with sporadic testing and limited data sharing that currently is not supported by best practice in well water sanitation. So the pilot study will explore the implementation of counseling to address resident concerns about covering costs associated with remediation. That's another one of the contributing factors that I had mentioned. And finally, program staff will work with local boards of health to adopt new private well regulations based on model guidelines implemented in states such as New Jersey and Connecticut. And again, these program activities are really I'm just rehashing some of what Jim had talked about earlier, but I'm presenting them here as in sort of a logic model format to show how these program activities are designed to address factors that contribute to lower rates of well assessment, well testing in parts of Massachusetts with high rates of contamination or suspected high rates of contaminants. So again, these activities, as you can see looking at the logic model, are expected to result in a number of short-term outcomes during the pilot phase, including changes in resident perceptions about the importance of water testing, increase in the number of wells tested for the Department of Environmental Protection advised contaminants, an increase in the number of remediated wells, and stricter local and state regulations requiring domestic wells to be tested for multiple contaminants during real estate transactions and new construction. In turn, we anticipate these short-term outcomes will lead to better informed private well owners increases in regular well water testing and Board of Health knowledge of water quality in their towns, a decrease in contaminated drinking water, and less variation in private well water testing regulation by towns in Massachusetts. So I know that's a lot of information, but really the logic model lays out almost the entire evaluation, and you can see how this information will inform the way in which we approach the pilot study. So as Jim pointed out, the project will be based in north central Massachusetts, where rates of potential contaminants are highest. 26 communities were eligible to participate in the pilot study. We selected 6 towns to participate based on a number of criteria, including things like policy regulations related to private well testing, proportion of residents obtaining their water from private wells, vulnerable population groups such as percentage of women of childbearing age and young children, and results of our preliminary needs assessment, which was conducted during the planning phase, and I believe Jim referenced that, regarding homeowner interest in well testing. Our evaluation is guided by 3 basic questions that will help us understand how the program was implemented, whether it produced anticipated results, and what these results mean for state and local decision makers. So we ask first, is the North Central Massachusetts Private Well Program implemented as planned? If not, why not? What factors facilitated implementation? What factors hindered implementation? What, if any, modifications were made to the program based on sort of a continuous quality improvement measures? And then second, what short-term outcomes are associated with program implementation? How much did outcome indicators change from before program implementation to afterward? And then finally, can these outcomes be used to inform stricter private well regulations in local Massachusetts towns? So we hypothesized that towns participating in the North Central Massachusetts Private Well Program will show, first, positive changes in resident perceptions about the importance of water testing. We expect to see an increase in the number of wells tested for Massachusetts Department of Environmental Protection advised contaminants, and increases in number of well tests with contaminants present in addition to PFAS. And as Jim explained earlier, the RCAP program is being implemented alongside a Massachusetts initiative to test for PFAS. So we're mainly focused on testing for other types of contaminants. And then finally, we would expect to see increases in number or percent of remediated wells. And in addition, we are expecting that implementation of the program will result in data that can be used to advocate for model, town, or statewide regulations. And by that I mean requiring that domestic wells be tested for multiple contaminants during real estate transactions and new construction. So to answer our evaluation questions, we are using what's called a quasi-experimental design, in which we first collect data on key outcomes of interest before the program starts, soon after the program has been implemented, and then again 1 year later. We will have a comparison group of private well owners in towns that are going to be delayed in receiving the program. We will control for, or statistically control for, alternative explanations that relate to town characteristics and regulations, and if necessary, control for how the program was implemented in different towns. And then we will collect data from the towns participating in the well program and those in the comparison groups. And as I, in this case, it's going to be a wait list comparison. So specifically, we are using what's called a modified stepped wedge design, and this is a depiction of that type of design. It is, as I said, a quasi-experimental design that includes an initial period in which no towns are exposed to the program. Then, at regular intervals or steps, groups of 2 towns will be assigned to cross from the control or comparison condition to the program condition under evaluation, meaning they will receive a well assessment, education, and water test, and counseling on remediation if needed. So this process continues until all 6 towns have crossed over to the intervention. Data collection continues throughout the study so that approximately 40 households in each town contribute certain kinds of data under both comparison and program or intervention observation periods. And as I said, this slide, it shows how the pilot study will be conducted. You'll see here how well water testing will begin in 2 towns in months 5 and 6. So that's Hubbardston and Boxborough. And months 5 and 6 are literally now, like May and June 2021. And then another 2 towns in months 7 through 8. And a third set of towns in months 9 through 10. Our original plan was to collect baseline data on well testing and contamination, as well as requests for well water testing in all 6 towns at 4 junctures. So you'll see here months 4, 6, 8, and 10. And here we did hit a bit of a snag, which I'm going to say more about momentarily. But we are also collecting data on health beliefs, and those will be assessed prior to and 2 months and 1 year following assessment and testing. So just so you know, calculations, we conducted calculations to see if we had enough households participating in the study to be able to detect an effect. And these calculations showed that we would need to engage many more towns, households, or include more steps in our design in order to have enough power to detect a program effect. And so because this is a pilot study, we have agreed with the funder, the Health Foundation, to proceed with an underpowered pilot test. We made this decision knowing that a subsequent implementation study will include many more towns, households, and steps, and have adequate power. The focus of the pilot is to work through programmatic and evaluation methods before evaluating on a larger scale. So here, you can see the data we are gathering that relates to program implementation. We are gathering data from a number of sources to document how the program is implemented and factors that might help and hinder that implementation. Implementation evaluation is critical because it can help determine whether implementation might account for program outcomes experienced. So for example, if there were issues with program implementation, we might see, we might not achieve the kind of outcomes we would anticipate. In addition to data on program implementation, we also will collect information on anticipated program outcomes, which you see here on this chart. It's important to note that neither the Massachusetts Department of Environmental Protection nor the Massachusetts Department of Public Health systematically collects data on private well assessments and water testing. So for data on well assessment and well water testing prior to implementation of the private well program, we have to rely on private labs to provide aggregate data on well assessments, water testing, and associated results. So we have found one large lab willing to share aggregate data with us for comparison purposes. Excuse me. And we plan to work with this lab to normalize or standardize the data for comparison purposes because it doesn't represent census data. This isn't ideal, but it does provide us with some comparison data. And again, this mostly speaks to the need for systematic data collection in Massachusetts on private well water testing. We're also going to be looking at well census data, which I think is supposed to be released this month, so that we have an accurate denominator. So we know exactly the proportion of wells we will be testing as part of the study based on the total number of wells in each of the towns where we'll be working. So to collect other outcome data, we are asking residents to complete brief online needs assessment prior to well testing and at 2 months and 1 year afterwards. This asks mostly about attitudes and beliefs and intentions related to well assessment and well water testing. We're also asking Board of Health staff to complete an assessment at follow-up regarding their perceptions of stricter private well regulations. We're asking a local lab to provide data on well assessments and water tests conducted as part of the program. So that's the prospective data I was talking about earlier. We'll be getting results as household wells are assessed and water tested. And RCAP will be tracking the number of remediated wells at 3 different points in time. So primary analyses will examine relationships between program implementation and outcomes. Analyses will focus on changes in testing rates and positive tests over time, controlling for exposure to or participation in the programming. Excuse me. Comparison data on well testing and assessments over time, as I mentioned earlier, of course, is restricted to this normalized data from one local lab in the region that conducts tests in the towns where we will be implementing the program. So specifically, the analyses will be applied to answer the 3 main study questions that I shared with you earlier. So this slide shows a kind of rudimentary formula for how we might conduct or how we plan to conduct primary analyses to demonstrate associations between program participation and outcomes of interest. So really what you're seeing here is what this shows is that outcomes of interest are associated with how well the program is implemented and the extent to which specific components are implemented as they were planned, and the context in which the program is implemented. And that means accounting for variations in town private well regulations, DEP testing activity, and so on. We plan to develop several interim and final products to share with different stakeholder groups. We anticipate that in developing such products, we not only will keep stakeholders apprised of our findings, but also force a kind of early examination of what is working and what's not working. And this would help us make mid-course corrections to the program or to how it is implemented. So again, this relates to sharing lessons early and often, rather than waiting until the end. And you'll see here, this again is a kind of rudimentary dissemination plan, but we do imagine several types of dissemination products that can be shared with different audiences for different purposes. And then finally, this slide shows where we are in the process of moving toward scaling the program. Jim described outcomes of the planning phase, which informed the pilot study that I just described. And the implications of the pilot study are threefold. So first, we went into this study knowing that we'll need to make some adjustments. Our purpose is to figure out what can work and where we need to make adjustments before advancing to a more rigorous and large-scale testing and dissemination. So findings from the pilot will be used to inform revisions to the program and to the evaluation methods and instruments. And that scaling up, of course, would include the current thinking is that it would include the remaining towns in north central Massachusetts, so 20 towns, and that we would use a similar design, the stepped wedge, where we would, towns would sort of roll or migrate through the intervention process. And then the second implication, in keeping with theories of system change, our pilot study will advance the program from the first step of identifying a promising innovation to the next steps of gathering evidence of whether, where, how, for whom, and to what benefit it might be successfully disseminated. And then a third goal, as stated earlier, is that preliminary data from the pilot study will be used to inform stricter regulation of private wells in Massachusetts, which in turn will facilitate wider scale dissemination of private well assessments and water testing and comprehensive data collection and sharing of test results. So that is my presentation. I'm sure you all have lots of questions for myself and Jim and Amie, and so I'm happy to take those now. And thank you for listening.
Thank you, Jim, Amie, and Kim. Sorry about the technical glitch there. I guess that's, yeah. So we do have a question here. I'll put it up. Let me find it here. From Eric Yankee. I'm glad Eric's on today. Is testing being repeated after remediation to ensure that the remediation plan is effective?
I can answer that. We're recommending after treatment is put in that the homeowner tests for just the contaminant of concern after they get a treatment system in. I usually have them run it for at least a couple of weeks to a month before they actually do the, a sample after that. But I recommend it, but it's not part of the program, so it would be on the homeowner to, make that cost.
Okay. So how have the homeowners been as far as, I know you went through a long process with your survey and all those things. Have they been very receptive, or just do you run into people who just aren't interested, or how has that been?
As far as getting the assessment done, or
actually,
or taking the information of the assessment, I should say.
Well, sure, both, I guess.
We've had great, a lot of people have been very interested. I mean, one of the towns were already oversubscribed, and the other one is closely getting up there in the first two towns. So the interest has been really good. It is mixed on the homeowners. I mean, some homeowners you get that they are willing to do whatever, and other homeowners will tell you that, they're not going to do it, even though you found a serious issue. And, I really look at it as my job is to tell them what it is and what the best way to do it. And, it's their water and their family, so it's up to them what they want to do with that information. But if I've done my part, I think I've, done all I can do. Sure.
Well, we actually haven't, we've had a few comments about talking, there was a thread going about MDEP and UMass and some of that stuff, but that's not really relevant for today. And so is there anything else you guys would like to add? I don't have any other questions for you from the audience. So,
Jim tends to be very clear in his presentations, and
you're
have questions afterwards.
We're getting some feedback. I couldn't understand that.
Oh, I think she was saying that Jim is very clear in his presentations. So, yeah.
Sure. Okay. Well, thank you all, and I appreciate your time, and I'm interested to see how this plans out. I'm glad I'm involved. It, if it gets to the point where I know you all hope it gets to at the end, and I understand that model regulations have no weight necessarily, but even adding that exposure, it'd be good. It's a good model to watch and see what happens. Your rules out east are much different than the ones we have in Illinois, which are also much different than the ones they have out west on water rights and all those issues. And so it's really it's not one size fits all, for sure. But I'm looking forward to what happens. So hopefully we can have you back when we get further down the road. So, all right. I'm checking to make sure here. Okay.
It looks like Jim's getting a message from Carol.
Yeah. Okay. Well, thank you. And so that's our presentation for today. And let me check my list here and make sure I don't forget anything. So we'll start bright and early for West Coast anyway. Tomorrow morning at 10 o'clock Central Time, which is 11 Eastern, and 8 o'clock on the West Coast. And so I don't have any other pressing wrap-up needs to share, I don't think, other than I apologize for that glitch. And, I guess that's the nature of the beast with doing these kind of events. So thank you all for attending, and look forward to seeing you all. Remember, when you log in to Socio tomorrow and go to the session for Wednesday AM, there'll be a Zoom link there. And, what I hope happens is if you have an issue that is really affecting your program in some way, or something that you've solved that's taken, years of, an aha moment for yourself, bring that with you and share it with the group that you're in, and we'll see how that all goes. So thank you all again for attending, and we'll see you tomorrow morning.